Hello, MTV. Welcome to my cribs. Miss Scavone here. I don't think you guys get any of that reference because you probably are too young for that. But welcome back. Unit 8, Clinical Psychology, Day 2. So today we're going to be talking about diagnosis and kind of the different categories of psychological disorders, and then some of the ways that psychologists are able to diagnose people with those disorders. So what I had you guys do for homework last night was read the Rosenhan study, talking about being sane in an insane place. So if you didn't read that, pause this real quick. Read through 227 through 235 on the PDF doc that I uploaded, and then complete the questions and ethical checklist that we're talking about. Because this kind of is the basis for what we're talking about today with reliability and validity of psychological diagnosis. So just to recap here, what Rosenhan was doing was trying to see if psychiatrists in mental hospitals were able to diagnose people and differentiate between people who were sane or insane. And again, these terms are not used anymore. Insane is kind of a derogatory term, so we don't use that term anymore. But let's keep in mind that this was like 50 years ago. So what they did is they had pseudo patients come in who pretended to have the symptoms of schizophrenia. So at first glance, they acted like someone who would actually have schizophrenia. But what we see here is that immediately, once they get admitted, they stop with all their symptoms. So to get admitted, they faked it and they pretended to have the symptoms. But once they're in the hospital, they completely drop the act and act completely normal. And then they're trying to see, well, how long can these people be acting completely sane? And obviously they are sane. They don't actually have schizophrenia. How long can these people be in there? And how long will they be forced to stay in this mental hospital when clearly they're not exhibiting any symptoms anymore? So what the results found, so there's actually kind of two studies going on. There was a follow-up one. So the first study found that the Confederates, and these are just the people who were kind of pretending in this case. So the Confederates claimed that they were hearing voices, and therefore they were admitted for schizophrenia, but they acted normal. Even though the results show that even though they didn't show any signs of abnormality, so any of the symptoms of schizophrenia like hearing voices, delusions, whatever, many of them ended up remaining in the hospital ranging anywhere from 7 to 52 days. And again, keep in mind that they're acting completely normal. They're not showing or faking any more symptoms anymore. But even though they were acting without symptoms and acting completely what we call normal, some were even held up to 52 days. So pretty crazy. And it shows how a lot about stigma, right? In that our labels can stick on things. And that's why it's sometimes not so good to have a diagnosis, because it creates that stigma and perpetuates that negative label and leads to a self-fulfilling prophecy. So what the second study showed, this is kind of the follow-up one, so then they told the hospital staff that they're going to have one pseudo patient, one or more pseudo patients coming in over the next 3 months. So again, pseudo patient is one of the fakers, so pretending to have an illness. So what they did was they had the staff rate patients who came in on a scale of 1 to 10 of how likely they were to be a pseudo patient. So what we see is that the staff in the hospital are being like hyper vigilant and really, really aware. What we see here is that then they start actually underdiagnosing, because when they're fearing for their credibility and they're being hyper vigilant and aware that they're being watched, they're actually much more less likely to make a diagnosis. So really, again, throwing some uncertainty into how valid a diagnosis, a psychological diagnosis is. So what I wanted you guys to do, this is a good review of our different ethical guidelines that we need to follow from the American Psychological Association. So go ahead and think through. Was there any informed consent? So obviously the Confederates, they knew what they were doing getting in there, but were the doctors and the other patients in the mental hospital aware that they were a part of this? Was there any deception? Again, did they know they were a part of this? Were they coerced into the study? So were they kind of forced or given bribes or that kind of a thing? And then was their info kept confidential and were they able to remain anonymous? And were the participants put at psychological or physical harm/risk? So here we're even thinking of the Confederates of the experiment, so the fakers, were they put at risk? Think about not being able to leave after 50 days. And then were they debriefed? So did they end up debriefing, let's say, the hospital staff and people who were kind of in on this? So lots of interesting ethical considerations to bring up. And again, this was taking place in the 70s. So something like this now might not be able to happen because there's a lot of ethical concerns for sure. So what Rosenhan's study brings up is what I want to talk about today that's really important, and this is the validity and reliability of psychological diagnosis. So let's take a sec to review real quick what it means for research to be valid and reliable. So we said that if a psychological test or a research study or something like that is reliable, think back to when you're talking about the intelligence unit, reliability means consistency. So if you're giving someone an intelligence test, like an IQ test, ACT, personality test, they're taking it multiple times and they should be getting around the same results. That's consistency, reliability. Validity is that question of, is the test testing what it's supposed to test? So is the personality test accurately gauging your personality? Is the ACT actually measuring college readiness, or is it measuring your test taking ability and is it not really predicting college success? So all good things. So validity is that it's actually doing what it's supposed to do. So now let's break this down into diagnosis. So if we say that a diagnosis of a mental illness is reliable, that means that two psychologists would give the same diagnosis to the same patient using the same diagnostic process. So you could have a psychologist in Australia and a psychologist in the United States, and they're both using, let's say, the DSM-5, and they're both giving the same, they see the same patients and they're giving them the same disorder. That's reliability. It's consistent. I could have a psychological disorder and go to 5 different psychologists, and they would all diagnose me with the same thing using that DSM-5 diagnostic guide. Validity in diagnosis is the extent to which the diagnosis is appropriate. So just the question of, is this a correct diagnosis? Obviously, Rosenhan's study brings up lots of questions as to the validity of psychological diagnosis. If people that are not actually mentally ill and not actually displaying, they're faking the symptoms, if they're getting diagnosed, that throws into question the validity of diagnosis. Are you actually diagnosing someone with the correct mental disorder? And is this going to result in a treatment that's going to improve the overall state of health and well-being for them? And the fact that people in Rosenhan's study, after 50 days of acting normal, were still not released, that throws into question this idea of validity. So what Rosenhan also brings up is just general issues in psychological diagnosis. So first issue that makes it really hard in general just to diagnose mental illness is that for the most part, unlike other disorders, you can't really do like a blood or urine test or something that's really easy. Think coronavirus, you can have a test that says positive. Obviously, there's some false positives, I think, or false negatives, but easy test, boom. You can't do that with a mental illness as much. It's much more subjective. There's not that kind of easy yes or no test with like biological things. Also, most disorders have many symptoms, and many of these symptoms are very similar to one another. So if you look in the DSM-5, which you guys are going to be doing for your little movie diagnostic project, like I said, there's a bunch of different criteria that you have to meet to have a disorder. So for example, major depressive disorder would say chronic period of sadness, extended, withdrawal from things you typically enjoy doing, etc. So lots of different criteria. And since so many disorders have so many different symptoms, how many symptoms are enough for you to get a diagnosis? Is just one enough? Or do you need to display 3 or 4 different symptoms? And it's also hard to measure symptoms. So a lot of this relies on self-reported data, right? If I'm saying that I'm sad, that's kind of a subjective thing. What is sad to me could be different to you. And when it's self-reported data, we said that the accuracy sometimes when you're talking about memories and things isn't always the most accurate, and you can't fact check that. So that's also hard if you're trying to report to a therapist or clinician kind of what you're feeling. And then we have cultural and gender biases. So, like we talked about before, schizophrenia type symptoms were completely normal in Ghana, whereas here that would be something that's pathological and abnormal. Gender biases. I talked about the issue of hysteria with women, and that they were attributing all these different symptoms that were really just other mental disorders and things like that to one that's just completely unique to women. So are women more likely to get diagnosed than men? Are men more likely to get diagnosed than women? There could definitely be gender biases in regards to mental illness that would result in over underdiagnosis of people of a certain cultural background or gender identity. Then we have this issue of comorbidity. So comorbidity is a fancy term that just means when you suffer from more than one psychological disorder at once. So maybe you have substance abuse disorder along with depression. So some disorders, like we're going to talk about with alcohol use or substance abuse disorder, is something that's comorbid, and that typically you find people that have that disorder also suffer from another type of disorder like anxiety or depression. And then finally, we have reactivity. So this is the idea that when people know they're being assessed and being watched, they might change the way they behave. So if they're being evaluated for having a disorder, they might be very aware of that and therefore not do the behavior they'd normally do. And that could result in a different diagnosis or a not so accurate diagnosis as well. So it's tricky. And this kind of brings up the question of like, does all the results from Rosenhan kind of invalidate our psychological diagnosis as we know it? Should we always be taking a diagnosis with a grain of salt? Kind of tricky questions that it brings up. So in general, when psychologists do their diagnosis, it's best to kind of do multiple different tests and things to try and make the most accurate diagnosis as possible. So 3 ways that psychologists can diagnose a mental disorder. One would be kind of what we think of a clinical interview. So like talking to a therapist, clinician, reporting your medical history, sharing a little bit about your symptoms that you're experiencing. And then if possible, we said it's very hard to do testing, but sometimes you could do drug toxicology screening, right, if you have a substance abuse one, or medical imaging, so maybe looking at the brain. Some disorders are much more biological than others, so some might be tied in with kind of the way your brain's functioning, things like that. And then other things like sleep studies. You could do a test kind of to evaluate something like narcolepsy and see it from that. And then we have psychometric assessments. So these are assessments that are standardized. You could do something like a depression screening, anxiety screening. If you're doing something like a developmental disorder, you could look at IQ testing, like Stanford Binet. Personality test, you could do something like the Minnesota Multifaceted Inventory, 16 personality factors. These are all kind of standardized ones. So at least you can compare it to kind of what's the norm and things like that. So you have a whole range of things that you can do beyond just a clinical interview, at least. So what we're going to do right now is I want you guys you can go to the actual Google Slides part of this if you're watching the video. And it's hard for me to play it on here, there's no sound. But I'm going to show you a video, and I want you guys to pretend that you're a psychologist diagnosing a patient for schizophrenia. So write down these symptoms. This is what you're going to be looking for, right? So these are the symptoms of schizophrenia. There's different types, but you can look for these general ones. So visual auditory hallucinations. So this is where you are really like seeing things or hearing things that aren't there, right? Hearing voices, seeing things. Delusions are just beliefs that are incorrect or not accurate. So maybe you believe that you're the president of the United States or something like that. Confused thoughts, disorganized speech, trouble concentrating, flattened affect, so just a lack of emotion. So look for these symptoms when I show you this video and see if you think that this person would qualify to be diagnosed for schizophrenia. So pause this, go watch the video, and then we'll come back. So, wonder what you guys put. When I do this in class, it's much better. But I think it's a really important kind of lesson is that this person is actually someone who's diagnosed with mania and not schizophrenia. So mania is actually a part of bipolar disorder, which we're going to talk about in a sec, which is the really bipolar disorder has the depressive moment and then the really manic moment where you're high energy, super active, reduced need for sleep. You're kind of just high, strong energy, and that your speech might even be scattered because of that. So why might these potentially be confused? I bet a lot of you didn't question that this was schizophrenia because you were looking for those symptoms. So this shows a big deal, a big problem with confirmation bias that could arise with different psychologists trying to diagnose patients. So, for example, if someone told you, oh, I think I have schizophrenia, or maybe their caretaker comes in and says, yeah, I think my son is displaying symptoms of schizophrenia, or another doctor tells you that referred it to you, then you're going to be having that in the back of your mind that like, schizophrenia, I'm going to look for these symptoms. And then that's all you're going to be looking for when very well this could have been, right, mania, and he could have had bipolar disorder. So confirmation bias, you're only looking for things that confirm what you already had in the back of your mind of schizophrenia. You're kind of ignoring the other things. So shows again that difficulty in being a psychologist diagnosing patients and how subjective it can be. So again, we have the DSM-5 to try and alleviate these problems. We want a standardized system so we can make sure we're being reliable and as valid as possible. But again, it's still very hard to do that. So now we're going to go over some different categories of psychological disorders. So these are broader categories that contain more specific disorders. So what I'm going to have you guys do in your notes is just kind of put these down, write a general description of what kind of the symptoms and explanation of what they are, and then what relevant neurotransmitters are involved, because that's a good review for AP exam too. A lot of this reviews over the bio unit, and we're going to talk about kind of drugs, agonists, antagonists, neurotransmitters, so that'll be a good review. So first category is depressive disorders. So this we're pretty familiar with, I think, right? So it involves things like extreme sadness, loss of interest in normal activities, and like we talked about yesterday, all these disorders are going to say something along the lines of causing you significant distress or dysfunction, those 4 Ds that we talked about in abnormal behavior. So 2 types would be major depressive disorder, and this is the more serious one that would last like 2 weeks or so. So it's extreme period and bout of sadness. And then there's persistent depressive disorder, which would be lasting like 2 years. And it's still serious, but not as intense and serious as the major depressive disorder. So relevant neurotransmitters for depression would be serotonin. And this is because serotonin is very involved in your mood regulation, in regulating your appetite, and in the sleep-wake cycle that we talked about with your different levels and your body clock and things like that. So that's why some kind of biomedical treatments for depression, medicine would involve things that would increase your serotonin levels. So it would work as an agonist, because people with depression have low serotonin levels. You want to increase those, so you'd want an agonist that's kind of mimicking or enhancing the effect of serotonin. So that's the kind of drug you'd want to treat depression. Norepinephrine is also something that's involved in kind of regulating mood, alertness, arousal, and this is also something that would be, think about it, would be low in people in depression who are having that, feeling tired, down, and that kind of a thing. So this would also, you'd want an agonist that would enhance that effect of norepinephrine in these patients. So the next one, kind of similar, but adding on a little bit, would be bipolar disorders. And this involves, you have to have both depression and mania. So, right, bipolar, you have the two very extremes on each side of the spectrum. So again, depression is the one where we saw this before, very sad, drawn out. Then we have mania, which is kind of just the extreme overreactivity, really high energy. You're not sleeping, you're up all night, you have all these ideas, flight of ideas. And that's what we saw in that guy in the video. He just had all these ideas coming at once, and sometimes they didn't make sense. And that could be kind of confused for schizophrenia when you're seeing the kind of, maybe it's almost like delusional at some points. So relevant neurotransmitters here are also serotonin and norepinephrine, because you see that when you're having those depressive bouts of bipolar disorder, you would be low on those things and need to enhance them. But also, norepinephrine could also be elevated when you're going through a manic episode, because you're like over alert and things like that, over aroused. And then we have anxiety disorders. So we're very familiar, I think, with anxiety. It's something that we hear all the time. So, but it's also sometimes not fully understood, I think, because there's lots of different types, and it's kind of just a word that we drop too easily. So anxiety, it's all related to fear and worry that's causing you distress or dysfunction in your daily life. But we have generalized anxiety disorder, which is just kind of a broad, overarching feeling of worry and dread. Specific phobias would be like, fear of spiders, something that's very specific. Agoraphobia is the fear of like social settings or being in places and not being able to escape and get out. So you have kind of a fear of going outside in the world. Social anxiety disorder would be that kind of fear of messing up and fear of judgment and embarrassment. So you fear social situations because of that. And then panic disorder is the fear of having a panic attack. So a panic attack alone is not a psychological disorder, it's a symptom of disorder. So panic attacks or panic disorder is the fear of having a panic attack. And then with anxiety, we see a related neurotransmitter would be GABA. And this is kind of the major inhibitory neurotransmitter. It's responsible for things like sleep and relaxation. So this would be, in GABA, you'd have low GABA would result in like a higher rate of anxiety. And then we have obsessive compulsive and related disorders. So we're pretty familiar with OCD. The obsession part of OCD would be that you have unwanted thoughts or cognitions that are really getting in the way of your daily function. And then we have the ritualized behaviors, and those are the compulsions. So the compulsions are the behaviors that you kind of have to do to relieve those obsessions and unwanted thoughts and relieve your anxiety. So compulsions would be, say, like an unwanted thought would be kind of the fear, feeling like you need to clean. And then the compulsion would be, like wiping off a doorknob or something like that. And it's going to relieve your distress or something like that. So if you think about it, actually, a review back to the learning unit, kind of the behaviors in OCD would be negatively reinforced, because if you think you have a compulsion an obsession, that's an unwanted thought, that's something that's bothering you, that's really troublesome and giving you distress, doing that behavior or the compulsion would then alleviate that stress and anxiety that the obsession's producing. So it's reinforcing that behavior by removing something that's unpleasant or negative. So, right, it would be negative reinforcement. So just a good review there, like we talked about. Kind of like that Tylenol example of you have a headache, unpleasant stimulus, you take Tylenol to alleviate and remove that unpleasant stimulus. And it's going to reinforce you that behavior of continuing to take Tylenol. Trauma and stressor-related disorders. So these are things that are a result of exposure to a really threatening event. So things, we really think of this as like going to war and experiencing combat, but it could be any kind of traumatic event. Sexual violence is definitely one that could lead to PTSD as well. So these would obviously cause you significant distress and dysfunction as well. Then we have the category of dissociative disorders. So these ones are very interesting. It's where the mind is separating from your mainstream consciousness and can kind of result in disturbances in your awareness, who you are, your identity. So these were previously called something like multiple personality disorder or split personality disorder. We don't use those terms anymore in psychology. The proper name would be like dissociative identity disorder. But this would be when you have those different personality breaks. And then somatic symptom disorders. So this is when, this is a good review too. We said soma is body. Remember we talked about the dendrites, nucleus, soma, terminal branch, terminal buttons, synapse. So soma is the cell body. So if something is somatic, it means that it's physical. So something psychological would be in the mind, something physical would be body, physiological, right? A bodily response. So these are disorders that actually have physical symptoms. So you might be experiencing pain somewhere throughout your body, but they have psychological causes. So it's a real thing. These people are actually experiencing that. They're not making it up, but it's physiological, physical symptoms of pain or whatever, but they have psychological causes. So this is different than if you heard of the case of Gypsy Rose with like a Munchausen's or Munchausen's by proxy, where you're making up that you have a disorder for yourself or someone else. That would be different. That would be something more like a fictitious disorder. That's what it's called. So that would not be a somatic symptom disorder, because somatic is they're actually really experiencing this. Whereas something like the Gypsy Rose case, a fictitious disorder, Munchausen's, would be you're not actually experiencing it. You're just making it up. It's kind of the cognitive part of it. Okay. Then we have feeding and eating disorders. So this would be things that have disturbed eating, food-related patterns. So anorexia, you are refusing food, you have a preoccupation with weight loss. Bulimia would be engaging in binging, eating a lot, and then purging, whether through taking laxatives, throwing up, things like that. Binge eating, right? Eating a lot. And then there's something called pica, which is one in which you're actually eating things that really aren't edible and supposed to be eaten. So an example would be, I used to watch that My Strange Addiction show, which was so bad on TLC. And that would be like someone I remember was eating like couch cushions or things like that. That could potentially be an example of something like pica. And then we have substance use disorders. And like I said, this would be an example of something that might be comorbid. Often you see with substance use disorders, typically these, not typically, but often there are people who have other disorders in addition to a substance use disorder. So they might have depression or anxiety. It's comorbid. And related neurotransmitters to these would be dopamine, because dopamine is kind of that pleasure center, the pleasure circuit. So these drugs, something like, let's say like cocaine or something, would block the reuptake of dopamine, which would cause more, because reuptake's when it's going and getting recycled back in. So it's actually causing more dopamine to stay, and therefore causing that pleasure sensation. Also, endorphins are kind of those feel-good neurotransmitters. So that would also be a relevant one when we talk about substance use disorders, which is all about getting that high and feel-good sensation. Okay, and then we have personality disorders. So these are quite interesting, and there's many of them, but these are kind of the main ones. So these involve long-lasting, consistent patterns of behavior and cognitions that are negatively impacting your function. So antisocial is when you are just kind of violating the rights of others. You don't really have a conscience. You're impulsive, just someone you wouldn't want to really be around. So this is in contrast to avoidant, which is when you're very shy and you don't want to interact with people. So antisocial in psych isn't so much like they're antisocial, they don't want to talk to anyone. It's like they're antisocial in that they're like really just, you don't want to be around them because they're so difficult to interact with. And then avoidance, more like the shy, you're avoiding people. Borderline personality is you're having difficulty with relationships. You might be kind of impulsive and have an unstable mood. So think borderline, you're kind of border all over the place. Narcissistic personality disorder, I think we hear about this one a lot. So you have kind of inflated ego, lack of empathy, a need for attention. And then similar to this is histrionic personality disorder. And I listened to an interesting podcast that was talking about, does Regina George in Mean Girls have this one or narcissistic personality? Because they're very similar. So this one would be very similar to narcissism, but you're more emotional and more dramatic in your attention-seeking behavior. So you're almost more needy than a narcissistic, someone with narcissistic personality disorder would be. So you guys can learn more about those if you want. I'll put the link to the podcast that I listened to. It's really interesting. It's a bunch of different psychologists, and they get together and they watch movies and they try to diagnose the movie characters with different disorders. So pretty interesting. Okay, then we have schizophrenic spectrum disorder. So schizophrenia, when we see something's on the spectrum, right? You're very varying degrees. You could have really intense schizophrenia that's completely disrupting your life and you really aren't with reality, or it could be much more mild. So schizophrenia is the much more intense one of these two, in which you're really experiencing those hallucinations, delusions. Schizotypal is also a personality disorder, and it's more like the scattered speech and thoughts, but it's not as intense as schizophrenia. And then reviewing some relevant neurotransmitters with schizophrenia would be dopamine. So dopamine, they believe you have excessive amounts would cause schizophrenia. So a drug treatment to schizophrenia, you'd want an antagonist that's going to block. All right, we said antagonist, anti. So an antagonist drug treatment would block dopamine because you're getting too much. You don't want any more. You're trying to lessen it. And then glutamate, they think that you have too little, and that's kind of your main excitatory neurotransmitter. So when I talk about schizophrenia symptoms, there's positive ones, in which when we talk about in psychology, positive is always adding something to the equation. So that would be like adding hallucinations, delusions, disorganized speech. And then negative is taking away things from the equation. So this would be like flattened emotions. You're lacking emotions, lacking feeling, kind of lacking speech. So that's kind of a review of how we use positive and negative terms in psych. And finally, last ones, we have neurodevelopmental disorders. So these ones are often diagnosed in early childhood. They're often related to cognitive functioning and sometimes social functioning. So intellectual disabilities, these are kind of related to things like problem solving, difficulties in learning, and cognitive kind of thinking. So these would be pretty normally diagnosed in early childhood by something, not, you might need more than just an IQ test, but often you'd see something like an IQ test, and we saw that to be categorized with an intellectual disability, you'd have to score below a 70. And we look at that bell curve there. And then autism spectrum disorder. So just like I said, schizophrenia is a spectrum. Autism is also something that's very much, you could be on either side of the spectrum. You could be extremely high functioning, or you could have more struggles when it comes to socialization and things like that. So DSM really tries to emphasize that, it's very much on the spectrum, and you could be all over the place when it comes to that diagnosis. And then ADHD, which we are also very aware of, I think, in our society. So what I want you guys to do now, just to kind of practice using the DSM and kind of getting a gauge for reviewing these disorders, I'd like you to complete the diagnosis scenario activity. So in your packets, I have the 4 different scenarios listed, and you guys can click on the little link to use the DSM. So read through the different scenarios and then decide what you think their diagnosis is and why. So pretend you're a psychologist. And then I want you guys to think about how valid and reliable your diagnosis was. So I will provide the answers on a separate doc. Don't use the testing effect, right? Don't look at them before you do it. And then I want you guys to then see how valid and reliable your diagnosis was. So typically what I do is when we were in class, I would have you guys do this in groups. So we'd see how reliable it was by seeing what all the other tables would say were the disorders. But unfortunately, I can't do that now. But I can see if you guys were reliable. But you can test if you were valid, if you were diagnosing the person with the correct disorder. So reflect to yourself, how does this kind of demonstrate some of the potential problems that could arise with psychological diagnosis? And then what can just be done in general to improve the validity and reliability of psychological diagnosis? Like I said with Rosenhan, does this kind of ruin all psychological diagnosis and invalidate them? Or should we take that study with a grain of salt and still say that most diagnoses are correct? So pretty interesting here. So I hope you guys found that interesting, and take some time to look through those disorders in the book if you want to learn more about them. I did not give enough explanation at all. It was very brief. So if you want to learn more, you can, and then decide what movie you want to do for your movie analysis summative. So pick a movie or pick a disorder and find a movie about that disorder, and then you'll do some research about that disorder and watch the movie and talk about what symptoms you see, how it's portrayed, is it perpetuating the stigma or stereotypes, or is it doing a good job, what are the inaccuracies, etc. So work on that, and then sign up for a time to watch 3 Identical Strangers. We're going to do that tomorrow and Friday. So sign up for that. That'll be a lot of fun. It's a really, really interesting movie, and I think you guys are going to be shocked. I remember when I first watched it, my jaw dropped like 5 different times, and it's a true story. So that'll lead for some really good discussions when we meet again. We will do a Google Hangout on Tuesday to do small group discussions on that. So make sure you're watching the movie. I'm going to have you guys create questions to ask one another about the movie. So make sure you're doing that. And then you can begin working on AP exam review packets that I posted. I'm not going to make those mandatory until later. So if you don't want to start them right now, you can take a break. But if you want to get ahead, you can get working on those. All right. Thanks for tuning in. Have a lovely day, you guys.